Left image is the axial graphic image through the midbrain, and it shows the subarachnoid hemorrhage in red throughout the basal cisterns. Given the diffuse distribution of subarachnoid hemorrhage without focal hematoma, statistically, the most likely location of the ruptured aneurysm is the anterior communicating artery. Right is the axial non-enhanced CT scan in a 63-year-old man who was found down in a parking lot, and it shows the diffuse subarachnoid hemorrhage throughout the basal cisterns. Note the enlargement of both temporal horns of the lateral ventricles, consistent with early extraventricular obstructive hydrocephalus. Left is the coronal MIP image of the CT angiography obtained in the same patient, and it shows a saccular aneurysm projecting superiorly from the anterior communicating artery. Right image is the coronal shaded surface display of the DSA obtained in the same patient, and it nicely shows the culprit aneurysm. This lesion was successfully coiled after this diagnostic DSA was performed. So left is the sagittal T1 weighted MRI sequence, and it shows the typical findings of acute aneurysmal subarachnoid hemorrhage. Note the dirty CSF that appears iso-intense with the adjacent brain. The normal basilar artery flow void is surrounded by the subarachnoid hemorrhage. Axial T1 weighted MRI in the same patient shows a nice contrast between the iso-intense with brain dirty CSF and the more normal appearing hypointense dark CSF in the cistern and temporal horns. Left is the normal CSF suppresses on FLAIR. FLAIR scan in the same patient shows that the CSF in the supracellular cistern is abnormally hyperintense. Sulcal cisternal hyperintensity is also seen in the left perimesencephalic and superior cerebellar cisterns, as well as the parieto-occipital subarachnoid spaces. Right is the axial non-enhanced CT scan in an 83-year-old man found down and shows diffuse subarachnoid hemorrhage, seen here as hyperdense fluid in virtually all the visualized sulci. CSF blood level is also present in the lateral ventricles. Left is the FLAIR scan obtained 2 days later in the same patient, and it shows diffuse sulcal hyperintensity and normally suppressed CSF in the lateral ventricles with blood fluid levels. Right is the axial GRE scan in the same patient, and it shows blood in the sulci as blooming hyperintensities. The blood CSF level in the lateral ventricles is also clearly seen. Left is the axial graphic, and it shows classic perimesencephalic subarachnoid hemorrhage. Hemorrhage is confined to the interpeduncular fossa and the ambient, that is the perimesencephalic cisterns. The source is usually venous in the perimesencephalic subarachnoid hemorrhages, unlike in aneurysmal subarachnoid hemorrhages. Right is the axial non-enhanced CT scan of a 49-year-old woman in the ER with a thunderclap headache. Shows subarachnoid hemorrhage around the midbrain in the perimesencephalic cisterns. Also note the absence of blood in the sylvian fissures and the anterior suprasellar subarachnoid space. Left is the axial non-enhanced CT scan in the same patient, and it shows the subarachnoid blood, which is seen to be extending inferiorly in front of the pons. Right is the coronal slice of the CT angiography in the same patient with reconstructed view through the basilar artery bifurcation, and it shows no evidence of aneurysm. The high density in the vessels is easily discernible even with the presence of significant subarachnoid hemorrhage. DSA not shown here confirmed the absence of aneurysm, and this case illustrates the classic findings in perimesencephalic subarachnoid hemorrhage. So left is a graphic of brain which is seen from the above, and it shows the convexal subarachnoid hemorrhage in blue color affecting the adjacent sulci but sparing the basal cisterns. Right is the axial non-enhanced CT scan in a 28-year-old woman with severe headache following delivery, and it shows the focal subarachnoid hemorrhage over the right cerebral convexity. Left image is the axial T1 weighted MRI in the same patient, and it shows the dirty fluid which is filling and effacing the normal sulcal CSF in the right convexity sulci, compared to the normal hyperintense signal intensity in the contralateral sulci. Right image is the axial flare MRI in the same patient, and it shows the hyperintense right convexity sulci, contrast with the normal suppressed hyperintense CSF over the left convexity. Postpartum vasculopathy was diagnosed at TSA. Left is the axial graphic, and it shows the darker brown hemosiderin staining on all the surfaces of the brain, meninges, and cranial nerves. Notice that the cranial nerve 7 and 8 in the cerebellopontine angle internal auditory canal are particularly affected. Right image is the axial T2 weighted MRI in a 64-year-old female with bilateral sensorineural hearing loss for 3 years, and it shows a thin black line which is coating the surface of the cerebellum, especially notable over the floculi. Left is the axial T2 star grease scan in the same patient, and it shows the extensive hemosiderin deposition over the cerebellar folia as curvilinear thick black lines. Right is the more cephalid scan in the same patient, and it shows prominent superficial sidrosis along the sylvian fissures and the medial occipital lobes. Left is the axial T2 star grease scan in a 51-year-old male with bilateral sensorineural hearing loss and remote history of resection of a left frontal oligodendroglioma. And it shows the hyperintensity coating the medulla, cerebellar floculi, cranial nerves 9 to 11, and staining the fourth ventricle choroid plexus. Right is the more cephalid scan in the same patient, and it shows the superficial sidrosis of the 7th and 8th cranial nerves, as well as the ependyma of the fourth ventricle. Left is the more cephalid T2 star grease scan in the same patient, and it shows diffuse superficial sidrosis along both the sylvian fissures and coating the midbrain top of the vermis. Right is the more cephalid T2 star grease scan, and it shows coating along the surfaces of both sylvian fissures as well as the interhemispheric fissure. Note the hemosiderin staining the ependyma, choroid plexi of the lateral ventricles. Left is the axial T2 weighted MRI in a 60-year-old male with progressive ataxia. Bilateral sensorineural hearing loss exhibits the superficial sidrosis, which is seen here as thicker and blacker. Cranial 8th cranial nerve. Note the cerebellar atrophy with large fourth ventricle and prominent folia. Right image is that sometimes the superficial sidrosis is limited to the posterior fossa. Coronal T2 star grey image shows the extensive superficial sidrosis in the posterior fossa. Blooming of the hemosiderin on the surfaces is seen as a hyperintense outline. The superior vermis is as well as the cerebellar folia are involved here. So coming towards aneurysms, these are the cases of saccular aneurysms. Left is a graphic which is showing the most common sites for the saccular aneurysms are the anterior communicating artery and the internal carotid and the IC and PC junction. The MCA bifurcation and the basilar tip are other frequent sites. Right image is a graphic and which is showing the rupture of an anterior communicating aneurysm with active extravasation from a superiorly directed bleb, which is called Murphy teat. An additional posterior communicating artery and tiny bleb at the left MCA bifurcation are seen. Patients with these saccular aneurysms have a 20% chance of having more than one aneurysm. Left is a 63-year-old man which is found down in a parking lot and brought to the ER. The axial non-enhanced CT scan showed a diffuse subarachnoid hemorrhage with a focal hematoma in the anterior-inferior aspect of the interhemispheric fissure. Right is the coronal MIP image of the CT angiography in the same patient, and it shows a 4 mm saccular aneurysm projecting upwards from the anterior communicating artery. Left is the image shows patent saccular aneurysms as rounded hypointense flow voids on MRI. This saccular aneurysm at the distal ICA bifurcation was found incidentally on the T2 weighted MRI of this elderly patient. The right image shows thrombosed saccular aneurysms can appear very hyperdense. This patient presented in the ER with sudden onset of right hemiparesis. The non-enhanced CT scan obtained as the initial study and the standard stroke protocol shows an ovoid hyperdensity with what appears to be thrombus in the left proximal MCA. Left is the source image from the CTA in the same patient, and it shows the abrupt cutoff of the left MCA and non-filling of a large completely thrombosed saccular aneurysm. Right image is the CT perfusion study in the same patient, and it shows markedly decreased cerebral blood flow in the left MCA distribution. The basal ganglia supplied by the lenticular-striate branches from the unoccluded proximal MCA are spared. A cerebral infarction can be caused by distal migration of clot from a thrombosed saccular aneurysm. Left image shows that some aneurysms exhibit mural calcification. This is a non-enhanced CT scan, and it shows an incidentally discovered saccular aneurysm, seen here as a well-demarcated rounded hypertensity with a peripheral rim of calcification. Right image is CT angiography image. It was subsequently performed in the same patient. Coronal BIP shows a patent saccular aneurysm at the terminal bifurcation of the left ICA.